Yes, sir.
Yeah, first of all, I want to thank you all for sharing your experience. This has been fantastic. It's really an upbeat presentation, giving us some hope out here. So thank you very much. I also want to say, Grace, you certainly earned your award that you received last night. There's no question. My question is just, do you have Red Bull coffee? What are you taking that makes you like this?
I'm a Coke Zero addict.
Coke Zero
okay?
addict.
Yeah.
Okay, very good.
About 6 a day, actually. And this is a Pepsi place. It's not been too good today.
Yeah. Now, the question I have in hearing your experiences and what you're doing with patients, shifting them to create access. You have to get them out of the high-cost access areas into lower cost. But how do you build capacity with that? If your practice is already at kind of the bursting at the seams with patients, what are your strategies to increase access for patients?
We're on? Can't hear that. I mean, it's an excellent question, and it's one of the things that I always talk about. And I look at the business of how we provide care as constantly changing. Patient-centered medical home doesn't mean you keep doing things the way you used to. 20 years ago, patient had an MI, was in the hospital for 2 weeks in a bed. 10 years ago, we were giving every woman estrogen replacement therapy. We change our clinical practices based on what we read and learn every day, but somehow we think our business practice can stay the same and it's okay. So when you look at a patient-centered medical home, part of this is probably half the people we see every day don't need to be seen in my office. They can be managed by someone else. They can be managed over the phone, by email, by text, by some other form, and still get good, high-quality care. We've got to figure out how to make teams and put teams into place as we do this. And we're going to struggle. It's going to be a challenge for certainly every primary care doc to do this. But even in specialty care, follow-ups can be phone conversations. Are you doing okay? As opposed to those 30 orthopedic knee follow-ups to say, you're okay, I'm okay, that don't need to be happening in your office and that's a global payment, but it can be done in other ways. And I think that's the challenge for all of us is care coordination, better use of PAs, of nurses, of nurse practitioners, of anybody else operating at the highest level of their profession. But we're not doing it either, and I think one of the biggest struggles we have is we all got hooked into EHRs, which are probably 5 or 10 years behind where we need them to be to do what we're supposed to do, because most of us in primary care are not functioning at the highest level. We're now being typists for about 3 hours a day. And so we've got to figure out how to change that.
Another piece of it is to say, in your practice itself, and looking at how you spend your time during the day, where are you as the physician adding value with the patient? Where are you being the doctor? And how do you take those other non-valued activities with a team approach, get them off of the physician or whoever's the care deliverer, and that'll open up capacity from the perspective of your resources and spreading it out to a care team. And that's a different mindset that a lot of us have been driven. It's all, you're in a practice, you're in your office, you're seeing the patient, but I will challenge all of us is that we are actually the bottleneck in our practices. We are the bottleneck because the systems are pushing on us to not only be a physician, but you're a coder, you're a biller, you're a data entry clerk. Right. All of those are non-value added from being a perspective of a physician, but that's also slowing us down. So how do you peel that apart in a different process perspective? That'll open up capacity.
Next question.
I'm a pediatric ophthalmologist, so that's about as subspecialized as you can get. And where I happen to practice is probably going to get carved up between CHS and Novant in terms of ACOs. So are you telling me that half my patients can no longer be half my patients because my group can only sign up with one of those?
No.
I think I heard that earlier.
I heard that earlier too, but if you look at most of the way that the ACOs are structured, the primary care, at least under the Medicare Shared Savings Program, are limited to one ACO. That's not true for specialists, which can sign up for more than one ACO. So, for example, in Greensboro, they are part of a Medicare Shared Savings Program through the Triad Health Network. Cornerstone is also part of the Medicare Shared Savings Program. We know that some of our patients will go to the ones in Greensboro and vice versa. We're having discussions and communication and collaborative discussions with the other ACO. They're not our rivals. The thing, when it was talking about attribution earlier, the patients can go wherever they want to in the system. This is not an HMO. You got it wrong if that's what you heard. This is an ACO, which means the patients can do whatever they want to. Okay, it's going to be up to us to see that they still go to the right place, the most cost-effective place, the best place for their quality. It's going to put an enormous burden on the providers to basically satisfy the patients from their needs standpoint. Once they have access to the exchanges, you may see the market flip overnight in 2 to 3 months. So, no, that's not what, I mean, the earlier stuff that was happening at the delegates earlier where they were talking about how, the contracts that are making people send somebody just to one network or the other. Cornerstone has no desire to do that in our contracts. We think patients ought to go to the most effective place. We hope it's us. And that's the way most of it's structured. Because most of these are PPO products, some of the products are making people choose a primary care physician, but they're certainly not making people choose networks like the old HMOs. That's not the way they're structured.
And you said that we had to start taking financial risk.
No, I didn't tell you to do anything.
No, not specialists, but, well,
Yeah,
not you, but
yeah.
someone was discussing about how part of
Yeah.
the problem with the business model was that
Yeah.
the business, us, had no financial risk.
Yeah.
Somebody said that up
No,
there. Okay.
you're right. I said that we don't take risk in our model compared to other industries.
Right, but I didn't hear anyone talking about the patient taking financial risk.
Once they go on the exchanges, when they're actually shopping for it, just like right now where they've got the higher deductibles, they are, and that's one reason many of them are shopping with their feet and not coming into the offices right now. If you look at the correlation between the high deductible plans where they're making choices, sometimes they're not making terribly good choices because they're not showing up for primary care, but there's a lot of correlation right now between the high deductible plans and patients' behavior. They most certainly are taking risk, and they're more and more of it actually right now in a lot of the plans. When the exchanges come along, I think it'll even be more so.
I'll just close with a comment that I'm having 1990s deja vu, and that there was some quote by an old dead British peer, the 4 most expensive words in the English language are, "This time it's different."
Well, all I have to say to that is, watch me.
Yeah, I have kind of two related questions. The basic one is how to attribute value, cost, non-cost to your providers, particularly when you come up with cost sharing and so forth, particularly when it's an integrated team and you've got a lot of players, some are playing better than others. How do you divide the pot? And then along those same lines, and a issue that we talked about this morning in the reference committee, if you have a cardiologist, an internist in New Bern who wants to send half their cardiac patients to Duke, maybe a much more expensive place. Patient wants to go there, doctor has relationships and wants to send them there. How do you deal with that?
Send them.
Well, this is, I think, one of the challenges that the ACOs, as it's currently structured, is facing. And when we went to CMS, that's the very question that I stood up and asked with direct marketing. You understand that this is not a HMO. Our 11,500 people, anything that's billed under their Medicare number is attributable to us. So we can prevent all the hospital ER visits we want to. We can prevent all the admissions we want to. If we have one patient that has an unnecessary atrial fib ablation because they see some fancy ad from Duke, or one unnecessary defibrillator, that's wiped out 10 to 15 hospitalizations that we've saved. So that was a political gift. There's no way this legislation would have gotten through if the patient had been restricted. That's my opinion. I made that comment there. Nobody said that I was wrong. They would have never gotten it through, so there are no boundaries on the patient. I asked them how they expected us to compete with that, and they said that their concept is, and I think my patients are like that. None of the patients that I take care of over the 32 years I've been in New Bern are going to go have an atrial fib ablation without talking to me first. But it takes a while to develop those relationships. And their concept is that if you build the kind of network and quality, they made the comment that the current medical system is like playing Twister. The patient has to move themselves to all different people. And their goal is to have teams of healthcare providers, like you were talking about, Charlie, where when open access to our records, we don't have schedules anymore. People call up for same-day appointments, and they come in, and half the people we see may be handled by our nurse or somebody else in that group. But that is very difficult, and I said, under these current guidelines, we're not sure we can save any money because of that. The other thing that's the biggest challenge that we have is control of our hospital patients. All of us have obviated our responsibility to our hospital people, and we have all got our own reasons that we did it. But we've lost control of those people. And when they go in the hospital, you have to prevent a lot of admissions to prevent one person that usually is taken care of as an outpatient by a cardiologist or an internist with atrial fib getting sent to an EP. They're not all equal, folks, and getting an unnecessary procedure that drives up costs. So there are some huge challenges of how we're going to control that, because we do not control where these people go.
Dr. Aller brings up a great point, and I think the number one is the usual source of care, that if you have a trusted relationship with a patient, they're going to ask you whether they should do those things or not do those things. That's what we do every day. But it's not necessarily saving money in the system, remember, it's bending the cost curve.
Yeah.
Okay? It's not that we have to take money out of the system. We just can't let the system continue to grow that much higher than the rate of inflation. So when you're starting from time zero, what we've said in our AC, with our contract is, we're not going to change who patients are going to now. We're going to start changing who the next patient goes to. So if you have a relationship with somebody, high cost, low cost, you can keep that if it's working for you. But in order to change that cost curve, we've got to change that referral pattern down the road for people who haven't been anywhere yet. So, and the question about how you do divide savings, we're not sure yet. I mean, that's the hardest part we've talked about, and our committees are starting to look at that, is we're going to have to get the data. You're going to have to be able to divide the data down by practice and then by provider within a practice. And then you're going to have to go to your partner and say, you cost us money. And therefore, what are you going to do differently in order to do that? You know, we saved $100,000, you cost $50,000, so you don't get anything, and you may have to take a pay cut next year on how to do that. Those are the things. But what we do know, if you use a community care North Carolina model with best practices, people don't like to be. We're competitive group physicians. We don't like to be at the bottom. So if you know that you're the low performer in your practice, you can bet within 6 months I'm going to be up to where they are. And if our practice is below John's practice, you can bet within 6 months we're going to figure out how to do that. Sharing that information, figuring out what they're doing different than we are, is what has to be done. That's the interdependence that we have to do.
Yes,
Yeah,
sir.
let me expand on just what you've said, Conrad, because that's really what I want to do, is to paint a word picture, a hypothetical, if you will, that gets down to the individual provider that you mentioned. I'm in a shared savings model. I'm primary care. I do everything right. I practice the preventive steps that are necessary to provide good health at a reduced cost. I use generic drugs, all of those things. But I refer to a specialist in the same group, and that specialist goes on ordering the high-powered technology and runs a big bill. How do you deal with those two different individuals in a shared savings model?
Part of the reason we're investing so much in our information systems is so we can break it down. Sometimes spending more on a patient is the way you save money. Sometimes it means that you spend more on somebody upstream in a chronic care condition. But one of the ways that you have to do that is you have to have access to claims data. That's been the big black mystery box that's been obscured from us. So when you take the clinical information we have in our electronic health records and databases and put some clinical decision support in there, and then you're able to add claims data back from the payers, then you can really start looking at things. For example, I was talking to some folks in an ACO up in the New England area. They didn't realize that they thought that their hips were costing a lot of money because their orthopedic surgeons were expensive. It wasn't the orthopedic surgeons. It wasn't the hospital. it was the long-term care facility. And greater than 50% of the cost of hip care was from that one particular long-term care facility. They had no idea. So sometimes information in and of itself is what you need. And right now, it's hard to answer that question when all you've got as a primary care doc is that little thing about you and what you've done with your diabetic measures or whatever. But in the world we're going to, part of it has to be based on access for many, many people, about many, many people. Yes, sir.
This is a question perhaps for Grace, since you have so many providers. On the one hand, through CMS, it's stipulated that you need 5,000 patient lives to form an ACO. That's basically 5 providers at 1,000
Right.
so-called patients being seen 4 times a year, what have you,
Yeah.
you know. But you're working on a model where you want to add people in the Piedmont Triad to become more efficient. So my question to you is, what is the minimum threshold of patients you think a group or a collection of groups needs to be at to truly be an effective ACO rather than at the bottom? Meaning, is it 10,000 lives? Is it 20, even though only 5,000 is
We
stipulated?
speculate that if you look at it from a comprehensive standpoint, about 20,000 lives, not necessarily of one contractor or the other, would be a good starting size for things. And most of the ACOs that have formed in North Carolina, even the smaller ones, have that capacity. If you look at the ones that allow the upfront payments, it was for physician groups of 50 providers or less in size. CMS was given the scale is important. The more access you have, the less actuarial risk you have. But even if you're a very small group, there's a place for you. It just depends on how you're going to interact with something of larger scale and what your place is going to be. Because if you can reduce the variability in the patients you take care of and improve the quality, then there's going to be an ability to aggregate that, whether it's in an IPA, such as what you've got with Crescent or with Key, or whether it's in a medical group or an integrated practice.
So then a follow-up question, what would you say to those 1, 2, 3 physician practices across the state as you take your chessboard or what have you, consulting thing, or what, I don't want to misspeak, but
Chess.
What recommendation would you have to those 1, 2, in the rural areas and so on, that are fighting to stay alive?
I believe that CCNC of North Carolina may end up being a real critical key, particularly for those in the rural health areas, as a network. If you think about it, it's across the state. It has hospitals that are part of it, as well as large medical groups like ours. You could probably come up with a hub and spoke model that would work just fine. The issue becomes how much information can you get integrated into those systems.
Thank you.
Just curious question for Newbert again. Very interested, your utilization, emergency room utilization, looks like it was going down significantly, and your hospital admission utilization was going down significantly. I'm just curious what the hospital administrator thought about that.
Well, I think, anytime you get here, currently the hospital administrator that we have in Newbern is very much behind our plan, because right now their incentives, as you know, the most frequent DRG in the country is congestive heart failure, and they don't get paid now for anybody who's readmitted within 30 days. So, and there are going to be more of those admissions. There's going to be admissions for people that get readmitted within 30 days after stent or after other things. So, obviously in the old days with HMO, empty beds in hospitals, it does seem like that there are differential alignments here, but if you look at it overall, there probably aren't. Our administrator is a good friend of mine, says that he loses money every day on every Medicare and Medicaid patient that he has in the hospital. Now, he probably doesn't because they're added dollars, but I understand his point. So I'm sure that there's a point at which they're not happy about it, but currently we've worked very carefully with the congestive heart failure case manager at the hospital to make sure that we're helping along those lines. So there's going to be places where we're going to trade some paint, as they say in the NASCAR, but I think it's going to be okay. And I think in the final analysis, we're really at the same level. We are really not doing what's in the best interest of our patients right now. We really aren't. And everybody who's been a practicing internist, everybody that had 2, 3 jobs like I did, where you went to the hospital, you made rounds, you went to the office, you went back, This system is not good for patients. To have somebody take care of them who never knew them, and all those systems are supposed to work without hospitalists picking up the phone and calling me and asking me what my opinion is. I don't know about in your place, but it doesn't happen in mine. So I think all in all, the patients are going to benefit from this, and I think that's going to be the bottom line. That's why I came away excited. It's the first time that I think we're going to do the right thing. We're going to all make less money, no matter what happens. Fee-for-service is dead. It's gone away. But we're going to be doing the right thing, and we're going to be happier. I think. I may be wrong.
I'm not sure we're going to make less money. Okay. If you had a global contract, Cornerstone looked at this. If we had a global contract on our current patient population and we were able to get 8% of the cost of care, of the global cost of care, whether it's out of the population we are currently taking care of, that would be an extra $250,000 per physician per year back to the Cornerstone physicians, just that 8%. Now, they think that there's a 30% waste that's out there in the system. Some of our docs think there's 50%. If you redesign the system, there may be more. Somebody will be making that money. Somebody's making it now. The real issue with accountable care organizations, quite frankly, is it's not about making less money, guys. I'm not planning on it. It's about creating a system where we will get that value by providing the value back to the customers that are wanting that out of us. And it's possible, and that's just with 8%. And so far, we're tracking okay so far just with the thing. Yes, sir?
A question about how you guys view our community care of North Carolina, potential changes. We've got a population that doesn't have to pay too much out of their pocket to go to the emergency room, the doctor's
Right.
office, wherever they want to go, because lots of times those co-pays aren't really collected anyway. How do you see that the next year or two we could modify the program to improve patient care and deal with these various things and where the patients go?
We've just hired Dr. Dave Talbot, who used to work for HealthServe over at the Cone Health System, to help us put together for Cornerstone a comprehensive approach to those patients that we think are going to come into our system. And we don't think it'll be overnight, but as you heard earlier, those dual eligibles, which are the Caricade ones, are where a lot of the spend is. And we think that if we can figure out how to give them very, very, very good care, not in the hospital, that over time that we'll be able to create a system to do it. It's going to require a lot of nursing care, outpatient. It's going to require new ways of analyzing it. And we absolutely see that CCNC can be a crucial part of this and ought to be, but it's probably going to require some redesign on some things. So we don't know that we've got all the answers, but we've gone ahead and invested in a physician with expertise in that to help us start building a system to do it. And I would imagine that all the CCNC areas out there, that needs to be a very robust conversation going on in all our communities. Has anybody got any thoughts about it?
Just to add to what you said, we're working real closely with CCNC on these patients. A number of them will be on their care management teams, and a number of them will be on ours. We're making sure that we're communicating with them during this process. One of the big things we found is transportation issues. We look at our claims where they come in, and we're seeing a lot of our dual eligibles that are repeated emergency room visits. We found a lot of that was access. They can call an ambulance, and they'll take them straight to the emergency room, but the ambulance won't take them to our office. So once we get those, we've gotten some of those systems in place, and those people are getting calls daily from our care managers, the ones who are in and out of the hospital a lot. We found that we've been able to get them into our urgent care center, arrange for transportation, and I think it dovetails real nicely with CCNC.
Yes, sir.
So a disclaimer first. I'm a member of the Leadership College, and CCNC is paying for that. So I work for CCNC. First of all, CCNC does not determine copays. That's Department of Medical Assistance, DMA. CCNC is a separate nonprofit that provides case management to these patients. So it's important to keep those things in mind. I work at Duke. We have high-priced cardiologists. I know that. We also are being thoughtful about looking at the patients from our Medicaid network who are in the ED a lot. And when we look at our highest utilizing patients, it's not the copay, it's not the timing so much. For our very high utilizing patients, it's mental health and substance abuse, overwhelmingly. It's not even close. And now we're beginning a dialogue and beginning to work with our emergency departments what to do when these folks show up with chronic pain problems. Often those pain problems are different week by week, but the solution that the patient proposes is the same. And when we can get our ED docs to change their interactions with those patients and say no, and say you need to go to your primary and we're not going to give you opioids, then those patients will stop coming. That's, if we look at our top 50 ED utilizers, 90%, that's the driver.
Behavioral medicine integration into the rest of healthcare is going to be real crucial to this. I absolutely agree. And in our heart failure clinic, apparently those heart failure patients with a diagnosis of depression are something like 10 times more likely to be the ones to go to the emergency room because they're less compliant. So we've got to be very, very thoughtful. And from all those lessons we've learned in our dysfunctional system, we're going to have to figure out how to create ways of approaching this. It is 10 minutes past when we said we were done, but there's somebody still wants.
Yes, kind of
Yeah.
real quick.
Yeah.
I was with Kaiser 20 years, and the buzzword in the 70s was adverse selection. Does that seem to be a problem with this model, or how are you dealing with that? The sicker the patient, the more work you have to do, and how do you account for that?
Well, I mean, John and I were just talking about it. We know that if you look at the system, it's the small segment that's using the majority of the resources. One of the things that care coordinators do is help identify those. And I actually did a panel with the medical side years ago looking at the compliance issue and why we think we know what causes non-compliance. It's all over the board. And so you really got to go to the individual to find out why they're non-compliant. Is it travel issues? Is it cost issues? Is it a home environment issue? Is it a cultural belief system? You name it, it's all over. But a care coordinator, a good care coordinator, can get to the bottom of that. So what we're looking at is we need to, when we get those patients from Blue Cross Blue Shield, we need to know who the high utilizers are. That's where we need to put our care coordinators in from the very beginning. Identify them, figure out, get them attached to, and this is one of the things we know, get them attached. One of the things that CCNC does right off, if an unattached Medicaid patient shows up in the ER, first thing they do, get them attached and back to a primary care provider so that they have somebody as a usual source of care. We do that and get those people back into us. I think you can start doing that, but certainly it's a struggle in our offices every day for the people that you take care of, and their A1Cs are still 13. Every quarter, 13. You're doing everything you can, still 13. So you're going to have to figure out how to get to that person individually. There are going to be some people we can't save. I mean, we do everything we can, still not going to work. But I think a team approach is better. Someone that relates to them better for whatever reason. But I think it's possible. It's just a different mindset from where we've been. And that's, I think, patient engagement. If you look at all these slides that talk about patient engagement, that's really what we got to figure out. How do we keep them from being obese in the first place? How do we get them not to be obese in the second place? How do we get them to be compliant, be active, eat well? We can't, social determinants of health, which we haven't even begun to start on now, is a huge part of this. And in places like Wake County and Durham, people can't there's no grocery stores near them. They can't go out and walk because it's a dangerous community. They have no education. You name it, there are all kinds of other things that we haven't addressed here. Mental health being the least one. Everybody knows that's a big issue, but our government don't want to deal with it, think it's siloed, completely separate.
Remember, in the old days with the HMOs, you were trying to get the sick patient to somebody else. In a risk-adjusted, global-based payment system, that's where the money is. You got to turn everything you think you know about what we're talking about on its head, because chronic care is where most of the waste is. If you look at CareMore in California, it had a medical loss ratio of 65. It's the most successful physician owned Medicare Advantage product that was out there. It was a group of internists. Their entire population was the frail elderly. So they dealt with COP epidemics during heat strokes by doing weird things like putting air conditioning in folks' homes. Really got to think outside the box, but if you actually address those that are the sickest from an attribution model, and if you're able to successfully come up with something, it doesn't take a whole lot, or you don't even have to fix all of them to take care of a few bills in the ER. I had a lady recently that came into my practice in my mid-level center to the ER where they spent $14,000 in 12 hours for what 1-cent Xanax for her panic attack would have probably taken care of the chest pain rule out. You don't have to win all of them, you just have to find a few of those. Thanks, everybody, for their attention this afternoon, and